and just ignoring aspirins, the drugs, and continue to use them and to keep it stable. But at the same time, anytime there is a tear in either one of these tendons or ligaments or a separation of the acromioclavicular joint, you will end up with excruciating pain and a decreased ability to move and increased pain on movement. So as much as we want the joint to be strong and stable, anything to do with a tear of the muscle or the ligament can cause an extreme amount of pain. A separation of that joint, the acromioclavicular joint, results in an excruciating amount of pain, and you actually can see a separation that occurs over the distal end of the clavicle itself and the acromion process of the scapula. If a patient presents with an excruciating amount of pain over the acromioclavicular joint, and the diagnosis is made that is what is causing the pain and decreasing the range of motion, that can result in the patient not being able to move the shoulder joint above a particular angle. An injection to the joint itself after doing an x-ray to make sure there's no other bony injuries, and if in doubt, an MRI definitely could be indicated, especially if the pain does not relieve, definitely could be treated this way. Other things that present with pain over the shoulder joint itself that is caused by the movement is a subacromial bursitis. The acromion process, as we actually said it's over here. Subacromial bursitis is a bursa that's under the acromial process that can become inflamed. Now just imagine that this is the subacromial bursa here. If it becomes inflamed, the minute you move the shoulder, it compresses the subacromial bursa against the underside of the acromion process, producing an excruciating amount of pain. Injecting of the bursa, either with something like a steroid or in terms of something for the pain, can decrease the amount of inflammation, decrease the swelling. Rest and physical therapy can bring it back to normal, and sometimes you end up with a normal joint. You also can have processes that tend to be affected. Is a tear in the supraspinatus muscle. That can result in a frozen shoulder. Frozen shoulder means you're able to get the arm up to a particular level, but you do not have the strength of the supraspinatus muscle, either because of a partial tear, to get it over this angle, which is the frozen angle. And in order to get it, you have to cheat, get it above use the subscapularis muscle, and being able to get it above the shoulder, and then you're able to lift it. That in itself is either, if it's not treated, if it's torn completely, it's a surgical operation to fix it. If it's partial torn, then it can repair itself in 4 to 6 weeks with conservative therapy, meaning in terms of medication for the pain and injection to the joint itself. Much more uncommon in our situation for us who tend to do either part-time physical activity during the weekends or play sports is the injuries involving the shoulder joints, the ligaments among the shoulder joints. As I mentioned to you, the supraspinatus muscle, the subacromial bursa, the evidence of the acromioclavicular joint, the ligaments around it. Much more uncommon is an anterior dislocation of the shoulder. Usually the patient will complain, especially if they've had a previous dislocation of the shoulder, trying to throw the arm out in a forward motion. The head of the humerus will then dislocate itself from the glenoid cavity, sits into the infraclavicular fossa, the arm will be rotated inwards, and you're unable to move that arm. It's easily reduced by applying traction, external rotation, adduction, and medial rotation, and it fits into place. The issue about that, recurrent dislocation of the head of the humerus, anterior dislocation of the shoulder joint, the more often it occurs, the more slack the joint becomes and the weaker the joint becomes. In fact, if it occurs for more than 3 to 4 times, it may necessitate having an operation. Posterior dislocation is when the head of the humerus, which is the same shoulder joint, dislocates itself posteriorly. Usually very common in a person who's going to go an epileptic seizure. That is a much more difficult joint to reduce. That's a more difficult dislocation to reduce. So joints in the pain in the shoulder joints, whether preventing us from doing our usual activity, either coming on in an acute or an insidious onset, usually it has to be treated after evaluation by the physician. Usually there are some things that are more common than others. If in fact you've tried the methods in terms of diagnosing and treatment, having done an x-ray to make sure that there's no overt fracture, you can apply heat treatment to an immediate injury, or cold if it's an acute injury that's occurred within the first 24 hours. Rest it as much as you can. Try to limit the amount of movement. If the pain persists despite the fact you've tried Motrin and other medications, then you should be seen by your physician. If after your physician has evaluated it, the pain continues, then definitely we will need to have an MRI done, an evaluation done by an orthopedic surgeon or a sports specialist. So shoulder joints are much more common in us. It gets more common as we get older, or we start to use the shoulder much more, and probably over the summer it will get much more as we go to the parks and play a lot of ball sports. Thank you, and that's all for now. One of the very common joints we see affected in family practice and patients presenting with pains involves the knee joint. The knee joint can be affected in several ways due to the injury to either the bony structure, the ligaments, the meniscus, or even the bursas that surrounds the knee. Even last night I was privileged to a discussion of a patient who had a Baker's cyst, and the discussion around this particular Baker's cyst was as if it was such a difficult diagnosis. If you understand what goes on in the knee, it makes it so much more simple and so much more easy to understand that injuries to the knee can be subdivided and injuries that occur around the knee and those that radiate from other joints, whether it be radiating from the hip joint itself that radiates to the knee, or radiating from lower joints itself that radiates to the knee. But if we were to focus on the knee itself, let us look at the anatomy of the knee. This is the femur, which is that long bone that we see in this picture here, and the distal end of it, of that bone itself, which tends to mushroom out to form the condyles, which now form that larger surface area that we all know that make our knees look larger than the rest of the bone above, articulates with the proximal end of the tibia, which is the major bone of the lower leg. The fibula itself is just a strut and does not articulate with the joint. So it's the distal end of the femur articulating with the proximal end of the tibia that forms the knee joint. When you look at this in an AP section, anterior-posterior section, you can see the lateral condyle, the medial condyle. Those are just the swellings. And you also find in between, there's a cushion that separates the two bones from jutting against each other, called the meniscus. The lateral meniscus and the medial meniscus. The lateral meniscus on the outside of the foot, the medial meniscus on the inside of the foot. You find that there's something called an anterior cruciate ligament and a posterior cruciate ligament. If you look at it as a cross section, the anterior cruciate ligaments attaches to the front of the tibia plateau, and prevents the distal end of the femur from sliding forwards. If in fact the integrity of this is compromised, then what you will have is slipping of this bone forwards and resulting in instability of the joint. You also have it being kept in place by the posterior ligament that holds it in place. So you have the anterior ligament, the anterior cruciate ligament, the posterior cruciate ligaments that now cross on each other, that keeps it in place in an anterior-posterior direction. Now what keeps it in position, that's the same anterior-posterior cruciate ligaments that can undergo tear, especially if you pick up a slide and you're able to stop yourself from falling. What keeps it from moving from side to side is the medial and lateral collateral ligament. Remember, we refer to this as being the lateral side or the outside of the leg. The medial collateral ligament keeps it on the inside, the lateral collateral ligament keeps it on the outside. If for any reason the medial or lateral collateral ligament becomes compromised, either from a tear, by the partial or complete, then you will have wobbling of the knee itself. The knee will start to give way. In addition to that, we have we mentioned the anterior cruciate, the posterior cruciate, the medial collateral, the lateral collateral. What keeps the knee joint from bone against bone, or from the cartilage of the distal end of the femur and the proximal end of the tibia from hitting against each other and prevent a grating sound. Usually you can get a grating sound when you've actually eroded the cartilage that separates the bone, It's the meniscus, which is made of cartilage. But the same process that can affect the meniscus, which is this cartilaginous structure, it can undergo tears. And these tears can cause actual separation of the meniscus. Now, when it occurs like that, it creates little areas that cause the knee joint to lock in itself. So partial tears or whole tears involving the meniscus, which acts as a cushion of the joint itself, can actually cause the knee to become fixed in a particular position and unable to move it forward. That is called locked knee in itself. If you look at this diagram, there's evidence of tear within the posterior tear of the lateral meniscus, and there's also another tear here. The treatment of these is definitely arthroscopy, getting into the joint with an arthroscope, putting water into both sides of the joint, and being able to remove the pieces of the meniscus that are torn, and the majority of times you get back full function of the knee after going through physical therapy for 4 to 6 weeks to get back the mobility of your knee and to give you the assurance that there's no more instability or locking of the knee. When you look at the knee joint itself, usually the advanced case of a lot of our patients as we get older and we lose the articular surface of the knee joint itself, and the bones themselves now are locked against bone because there's no longer there's just the bone, the distal end of the cartilage, the meniscus have all been torn. We develop severe osteoarthritis based on a simple fact of either overweight, degenerative uses, or ignoring the fact when we are actually told to get it looked after. And now we have to get a total or a partial knee replacement. The partial knee replacement involves one portion of it, and the other end of the distal end of the tibia itself is maintained, and a total replacement is when both sides of it is replaced. In a case like that, usually the results are quite good. It does not give someone the mobility that they had before, but it makes them at least being able to move much more freely without having to worry in terms of taking an enormous amount of tablets for the pain. Other things that actually affect the knee joint itself are the bursas around the knee joint. In this particular diagram, I don't have any, but basically you have a prepatellar bursa, which is on the anterior aspect of the knee itself. It's over this area, usually very common in people who do a lot of kneeling when they clean, and that bursa can become inflamed. When it becomes inflamed, it presents with pain over the anterior aspect of the knee and inability to flex and extend the knee as much as we would like to. The infrapatellar bursa, which lies under the tibial plateau, usually very much more common in people who do a lot of kneeling, especially the clergy, and when it becomes inflamed, can present with the same amount of pain. Here the treatment is, first of all, to take a proper history and being able to diagnose adequately what is going on with the patient. Usually, most physicians will be able to figure that over where the areas in the anatomy of the area, exactly what's causing the pain, provide a treatment in the form of medication, physical therapy, or maybe injections. If the pain persists, then definitely you need to get an MRI done to see exactly if it's a meniscus being involved, if it's a medial collateral ligament, the lateral collateral ligament, the anterior cruciate, the posterior cruciate, or the meniscus. And if there is a tear, then definitely you need an interventive procedure that the orthopedic surgeon is the only one who's qualified to do. So knee injuries in themselves, even though it can be divided into acute and chronic, usually in general, if you take a look at the anatomy of the knee itself, can usually be very, very helpful in terms of early treatment rather than trying to wait for it to get better without actually seeking the attention of a physician. It's much more common at this time of the year, especially since it's the summer months, and we tend to be much more active on the outside. And when we actually overuse the knees itself in chronic running, we can also be actually exacerbate previous injuries. So my advice to you in the event of knee pain presenting itself is to consult your physician for an adequate assessment and diagnosis and treatment.